Thanks, Solomon sir, for the invitation for hosting, moderating the session. This is Dr. Arvind Kumar. Are you hearing me?
Yeah, we can hear you.
Hello, this is Dr. Arvind Kumar trying to moderate the session. Thanks, Dr. Solomon sir, for the opportunity. So this is the we have experts like Dr. Makale, Dr. Keshava, and Dr. Saurabh Banerjee along with me, and we have Dr. Arun Kalyan Sram along with me as a moderator. We have the stalwarts all specializing in complex as well as in acute coronary syndrome experts. I just call upon the experts to take over the session and bring in the presenters so that the session moves on as quick as possible.
Nice. Should I start sharing screen? Can I start sharing the screen now?
I think we are ready to start.
So should I share screen now, Subro?
Yes, sir.
Please,
Just
please,
go ahead. Because the expert
Harish.
will be coming in. Sir, please, Dr. Harish Mehta, sir, please go ahead and start sharing your screen.
Okay, can you see the slides?
We are able to see the slides, sir. Please proceed, sir.
Just give me a minute. Yeah, okay. I don't know why it's not going to this fine, but I'll have to run it like this. I don't know why it's not going to screen. No, it's not going to slideshow. I don't know why. Let me try it once more and then we'll go. Is it gone into slideshow? Yeah, it is, right? Are we ready? So my talk, it is a long talk, which I'll try to make it short. Implication of post-dilatation in ACS, when to call under expansion, do we use MSA or MSE? So we know by this BASE ACS trial, which was conducted, the largest trial that conducted 14 centers from Jan 2009 to September 2010, involving 827 patients, comparing bioactive stent versus everolimus stent. And of these patients, 42.3% underwent post-dilatation, and they found that patients who underwent post-dilatation had less frequent non-fatal MI events at long-term follow-up compared with those who did not. This was one of the major trials which opened up the need of post-dilatation in acute coronary syndrome. This was followed by intravascular ultrasound findings of early stent thrombosis after PCI, primary PCI, and acute MI. And in this IVIS sub-study, Horizon MI clearly showed the two predictors of stent thrombosis was minimal lumen CSA less than 5 and residual stenosis and dissection. So this was clearly the reason that there was more stent thrombosis. That brings us to the definition of stent under expansion. It is often defined as the failure to achieve minimal in-stent dimension greater than 80% of the average segment diameter. Incomplete stent opposition also needs to be mentioned here. It's separation of one or more stent struts from the underlying vessel wall. Although there has been evidence that post-balloon dilatation achieves better angiographic results, there have been concerns regarding the risk of this practice, particularly in MI patients, when some studies showed increased all-cause death in patients, although the MACE was not affected. Stent under expansion therefore remains an important predictor of early stent thrombosis and restenosis, and it is well recognized that stent implantation based on compliance charts can never achieve adequate stent expansion, especially in DES. There are limitations to evaluate these extent of stent expansion, as we know, by coronary angiography. And the causes of stent under expansion have been procedural techniques, lesion-related, stent delivery balloon usually may be undersized, especially in acute coronary syndromes or MI situations. Improper taking of the proximal and distal reference vessel diameters, mainly the proximal, and the inflated balloon pressure could be inadequate. If you remember, this POST-IT trial and the COSTA trial clearly showed that only 25 to 30% of stent could be expanded properly, because this was the problem with the semi-compliant stent delivery balloon. And this was seen more with longer stents and with stents with and lesions which have a differential sizing from proximal to distal. So these were the common causes that there was under expansion, and under expansion and MSA go hand to hand. If your minimal stent area is less, then it is an indicator of under expansion. It has been clearly seen in multiple trials, as you can see here. As I already mentioned, the ADAPT DS, the Horizon AMI, MGH OCT, CLIP OCI, and ADAPT DS formed a part of the Illumin 2 trial, and this also gave us more evidence that OCT and IVUS could be used to optimize expansion. So if you clearly see this angiogram, this is the first DS, and you see that the minimal lumen area, the minimal stent area was 3.45, which was clearly less and not good. And after post dilatation, you attained an area of above 4.65 to 6.03 in panel C, then it clearly tells you that the stent expansion was inadequate in this patient. Similarly, in this patient, you can see malapposition, which is very clearly seen here in IVUS and also on OCT, if you see here, and these red markers telling you this malapposition. So malapposition and stent under expansion can happen together, but a well expanded stent can also still be malapposed. So we need to differentiate between the two. So what are the cutoff values in imaging for under expansion? In IVUS, there are very clear-cut criteria of varying between 5 to 8. Anything above 8, it loses significance. The plateau is reached at 8. In OCT, there is no clear-cut criteria, but there have been studies which saying that cutoff value of 5 for DES or 5.6 for bare metal stents, and somewhere it's shown 4.5 MSA was associated with major cardiac events. But again, this is not very well documented in OCT as compared to IVUS. And in Illumin 3, OCT less than 5 was found in about in 1/3 of patients, almost in 30% in the OCT arm. So early clearly telling you is a small stent area under expansion is not infrequent even in contemporary practice. Another important concept to remember is the tissue protrusion within the stent. So any tissue protrusion exceeding more than 10%, whereas tissue protrusion CSA divided by stent CSA, if it's more than 10%, then it's a harbinger of target vessel failure. So this is also very important measurement to be noted in patients, especially if you're dealing with ACS or MI patients. And this tells us a small procedure MSA correlates with small MLA area at follow-up and explains the risk of device-related cardiac events observed in this study, which was driven primarily by excessive TLR. Acute malposition has been seen more with OCT as frequently because there is better imaging you see versus 39%. But an important thing to remember, if the stent is well opposed, then neither OCT or IVUS detected acute malopposition had been associated with adverse early or long-term outcomes regardless of the amount of malopposition. So under expansion carries more importance than malopposition. Not that malopposition has no role, but under expansion has more sequelae of restenosis and later events compared to acute malopposition in a well expanded stent. So should we depend on MSA or MSE? MSA, as you know, is the minimal stent area, and MSE is the mean stent expansion. Now, this is a very beautiful example which will tell you, if you watch here, the MSA distally is 5.92, but the expansion limit is 79%. So are we going to accept the MSA and stop here, or are we going to try to optimize it? And similarly, if you watch here, was deployed with only a couple of struts into the left main. So your expansion is 42. Again, this is wrong because your expansion is taking the proximal LAD with the left main diameter. So you cannot try to expand this stent further because there's only a couple of stents into the left main. So you need to know what is more important in which patient. So in this patient, distally, despite an MSA of 5.92, I would want to expand this stent to get it to 85, 90%. And I would not expand the proximal stent to get it to 90% because it's not possible in this case. So this is very, very important. Similarly, if you have a distally small vessel where the MSA is already going to be small because the MLA is going to be low, in this case, your expansion is 81%. So you may make it 90%, but you cannot attain an MSA of 4.5 or 5 over here. So you have to really clearly know when to use MSA, when to use minimal stent expansion. So this is an example which tells you that how do you use both these. And does OCT optimize results of stenting? This is very clearly seen in the doctor's trial where they showed that the procedural optimization was better with OCT guided stent. and additional stenting was needed, but the overdilatation helped in improving outcomes. And as you see here, the percentage diameter stenosis final after angioplasty went down in the OCT guided group, and the stent expansion went up in the post-optimization group. So this was clearly an indicator. Similarly, Illumin 3 results, the final post-PCI MSA assessed by OCT versus IVUS, told us three important things: that it is superior to IVUS guided PCI detecting certain predictors of major adverse event, especially major dissection and major malapposition is better seen with OCT. Although the acute procedural success between OCT and IVUS was the same, although it was superior to OCT versus angiogram, and MSA was comparable with IVUS and OCT. Now, another important thing to remember here, the MSE is helpful because MSA in OCT is generally less than the MSA in IVUS. So for better comparison, MSE would be a better thing because it's a percentage rather than an actual value. An actual value, OCT will be lower than IVUS. Finally, coming to my last part of the talk, where the Light Lab initiative, where the total of 2,200 procedures were assessed in the phase of Light Lab program. Everybody of us knows about this Light Lab. And here they came with the concept of MLD max, whereas in the beginning, when you do a pre-PCI, you look at the plaque morphology, the lesion length, and the vessel diameter. And then there's the angiocore registration, and post pullback is very important to look at the medial dissection, look at a dissection which also leads to MACE, distal or proximal. Stent apposition is very important. And last not the least, stent expansion, which can be measured with MSA as well as MSE. So what it told us, that lesion assessment and treatment decision that impact final stent expansion, the cumulative OCT impact was 88% in these patients. So these are a number of IVUS studies that have demonstrated the MSA is the strongest predictor of stent thrombosis and restenosis. This is the differences of OCT versus IVUS, which we all well aware, which is now standardized. So to conclude my talk, the things to remember is late acquired malposition could be attributed to positive vessel remodeling and or plaque thrombus resolution. This is seen more in ACS patients. Hence, imaging will tell you more the lumen size, the vessel size, whereas angiographically you may undersize the vessel and may not post-dilate. I would say post-dilation with non-compliant balloons after stent deployment has been shown clearly to enhance stent expansion and could reduce PVR and stent thrombosis. Although in ACS and MI it has been controversial, I would probably lead more towards a good pre-dilatation strategy and post-dilatation if necessary, if documented by imaging. Imaging will play a vital role in ACS, both in diagnosis as well as optimization. And MSA and MSC both are important, but you should know when to use the MSA, when to use the MSC. Expansion is important. You need to have the expansion, but you need to know where your vessel is deployed and what is your reference vessel diameter and which method has been used to calculate the MSC. Either the taper method, where they use the branch vessels to find out how the vessel size changes from proximal to distal, or if they're divided into two. So knowing your instrument is very important. Finally, post-dilatation with an NC balloon to achieve optimal stent expansion and maximum luminal area is a logical technical recommendation, particularly in complex lesion subsets. Thank you.
Thank you, sir. Thank you, Dr. Harish Mehta, sir. I request the panelists, expert panelists, to give a comment also because we are running short of time.
Yeah.
Sir, please, one comment from our expert panelists.
Yeah, thanks, Harish. I think that's a very interesting talk. And I think one of the learning points from here is to answer the question, which one should we take into account? Is it the MSC or the MSA? We should take into both, but the important message is it depends on the vessel. So you look at the vessel and you look at the values, and then you decide which one you would give more importance.
Yeah, I agree.
Any other question?
Sir, if there is no more further discussions, I will move to the next case, sir.
There is a question, I think, from Dr. Macaulay.
We'll move on to the next case. I request our
Can I ask one question?
Yes, please go on.
Particularly in the setting of the acute myocardial infarction, if the stent is undersized, or does the OCT help? Because there can be the plaque prolapse after the post-dilatation. So how does it help?
Yeah, so if you have significant plaque prolapse with compromise of the lumen, then it's clearly you need to put another stent, Dr. Markle. So that's OCT will clearly help telling you that if it's more than 10%, then this patient needs to be treated with another stent. You need another drug-eluting stent there.
Okay. Because we tend to oversize during the acute infarcts, during the PAMI situation. Okay, we'll go ahead.
Yeah. So next speaker is Dr. Tom DeBassia. Yes, please go on.
Please let me know when you can see my slides.
Yeah, we can see your slides. If you can go to the slide mode. Yeah.
So please keep the time on to the.
Yes, sure. So thank you very much. Can you see my slide?
Yes.
Thank you very much. So warm regards to all of you from Kasturba Medical College, Manipal, Udupi. Does all patients with ACS need a stent? We all know that ACS has different mechanisms. It could be a plaque rupture, a plaque erosion, or an unstable calcified nodule. The one on the left is a plaque rupture. We can see the ruptured thin cap fibroatherom, which has emptied its lipid content with the necrotic core into the lumen, which acts as a highly thrombotic material and uses an intense inflammation and cause ACS and a lot of damage. Whereas the one on the right would be plaque erosion, and we'll come into it shortly. In plaque erosion, you can see that there is absence of superficial lipid, less inflammation, and very commonly less obstructive lumen. Plaque rupture has significant plaque burden and causes significant obstruction. The thrombotic core is the necrotic core is quite thrombotic, and the disrupted fibrous cap, as I have already mentioned, is inflamed and causes occlusive thrombus. Whereas in plaque erosion, the vascular integrity is preserved, the fibrous cap is intact, there is significantly larger residual lumen in most of the patients, and there is platelet-rich thrombus, but the fibrin level is less. Plaque rupture is the most common cause in about 60% of ACS patients, whereas plaque erosion is responsible for around about 25 to 40% of ACS. Now, the standard therapy have been for all patients stenting, whether the underlying mechanism or pathology is plaque rupture or plaque erosion. However, subgroup analysis of several clinical trials suggest that this strategy does not provide an equivalent benefit for all patients. Like, for example, current smokers, young people, women, there are a significant patient population for all of us. Now, if you compare plaque rupture and plaque erosion, the stenosis of the lumen may not always be significant in plaque erosion. If you keep 75% of the area stenosis as the cutoff level, 60% of the people with plaque erosion do not have significant stenosis, and round about 35% of the people with plaque rupture do not have significant stenosis. This was published by Kramer in 2009 in JACC. And more platelets and less fibrin has been noted in eroded plaques. And the past data tells us that the erosion study, which was a proof of concept study in China, which was published in European Heart Journal in 2017, where a single stent had 400 patients with ACS, including ST elevation MI. After thrombus aspiration, an OCT was done, and plaque erosion with less than 70% stenosis people were managed medically. That was round about 25% of the total study group people. And on 1 month follow-up, the thrombus volume decreased. They went ahead and did an erosion study 1 year follow-up, where they followed up 53 patients, and 93% were free of MACE on aspirin and ticagrelor, and they published it in 2007 in Circulation. And in French data in 2017, the Archives of Cardiovascular Disease, young smokers with ACS underwent OCT-guided two-step strategy. First, they did OCT within 1 week of ACS, and then the next OCT was after 1 month. And they realized that patients had improvement because of probable recovery from vessel spasm and or a high intensity statin dose because the plaque volume came down and the luminal area went up. This is another publication in 2017 in Journal of American Heart Association, where they studied OCT data retrospectively of around about 140 patients. Plaque erosion patients were more likely to be treated with medical therapy and relatively free of disease up to 1 year. Those patients with plaque rupture had higher malapposition, tissue protrusion, and thrombus. And now, what is the role of OCT in ACS patients? OCT can, of course, demonstrate plaque rupture or erosion and tells us the mechanism. With high resolution, the mechanism can be defined. We can have a reproducible data, and it can be performed safely and fast in patients once antegrade TIMI3 flow is established. What is the rationale for treatment with antiplatelet without stenting? The thrombus volume diminished over time under optimal medical therapy that monitored by FT-OCT, published in 2015 in European Heart Journal by Ambile et al. Antithrombotic therapy, including the dual antiplatelet and a short course of anticoagulation, prevented further cascade of the coagulation system. The endogenous fibrinolytic system promoted thrombus dissolution. The eroded plaque did not have large necrotic core. They exhibited a proteoglycan-rich matrix and smooth muscle cells. There was less tissue factor and less tissue inflammation, and hence lower local thrombogenicity. In 2013, in the JACC, Prati et al. Retrospectively investigated 31 patients with STEMI and published that after thrombus removal with thrombus aspiration, OCT showed the intact fibrous cap, showing it is plaque erosion, and there was no significant residual obstruction. People were divided into two groups. 12 of them did not undergo stenting, and they were treated with antithrombotic therapy, and none of them developed any events or required an additional revascularization at 1 year follow-up. Whereas in people with plaque rupture, if you look at the outcome, there is release of highly thrombogenic substrate. It induced recurrent local thrombosis. There is damage to microcirculation. There is obviously worse outcome. Of course, when we put a stent, there is problems related to acute stent complications, including dissection, protrusion, malabsorption, malapposition, and thrombus, and higher frequency of distal embolization. In 2015, in European Heart Journal, Nicoli et al. Demonstrated that patients with plaque rupture had a worse prognosis after 3-year follow-up, mainly driven by revascularization and unstable angina. Whereas patients with erosion had a favorable clinical outcome if they were treated conservatively. And this highlights the new concept that conservative therapy in ACS patient after thrombus aspiration without stent implantation is feasible and safe. Only thing is that it has to be demonstrated in large randomized controlled trial. So in short, the take-home message would be, in patients with ACS, including ST elevation MI, 25% of patients after thrombus aspiration, if we do an OCT, and if we confirm that the mechanism of ACS is plaque erosion, and if the stenosis severity is less than 70%, medical management with optimal dual antiplatelet therapy, including ticagrelor and statin, is a good option and has very limited MACE at 1 year follow-up. However, these studies all have been small group, and probably we need a large randomized controlled trial for confirmation. Thank you very much.
Thank you, Dr. Tom Deveshia. I request Dr. Saurabh Banerjee, Dr. Chandrasekhar Magle to take the session. I will ask for one question so that we are running short of time, sir.
Pardon, can you repeat the question?
It will definitely reduce the instances of stenting during the primary PCI.
Yes, it is just that we should focus that just angiogram, which is a luminogram, is not the answer to leave the patient on medical management in people with ACS. It has to be driven by OCT or other similar advanced imaging modality.
There are two things. One is an inter-observer error. You really need to have the trained person even in the middle of the night to analyze that. And finally, you have to have the gut feeling that, look, here I am and I'm not going to stent it electively.
Yes.
Yes.
I agree, the trials are there, But
We have to be, like, I fully agree with you. We have to be 100% sure by OCT that there is no plaque rupture in the study, and getting a very good image is very, very important to take this decision.
Yeah, just one comment. Do you not think that it would actually increase the number of stent implantation? Because normally if it's say something like 40-50%, we wouldn't bother to stent it. But we do an OCT and we find there is a plaque rupture, we would be stenting it. So actually the use of OCT may increase the number of stent implantation. But yes, but in that, the other question is, do you think you would advocate then OCT for all patients with ACS where there is vessel is somewhat recanalized? And you need to know whether it's a rupture or a erosion or a calcific nodule?
I personally believe that, and I also feel that if we decide to leave a patient on medical management with ACS, whether it is STEMI or NSTEMI, without stenting, you should make sure that you do an OCT, get a wonderful image, make sure there is not a single plaque rupture before you leave the patient on medical management, because the patient has only one life. For you, maybe it is just one case.
Yeah. If there is
One
no other
segment at the
question,
end, I will
Yeah.
move to the next case, I
Yeah.
believe. I request Dr. Rajanath to give his presentation.
Thank you, sir. I'll start sharing my screen. Is my screen visible?
yes.
Can you hear me?
Yeah.
Okay. So basically, I'll be presenting two cases of STEMI in left main, and one of them will be with image guided. So two short cases, not very eventful. So this is the first case, who was an 84-year priest, who happened to be the father of the same school from where I passed out. He was a diabetic, hypertensive, and had multivessel interventions in LAD, LCX in 2011. He presented in 2017 with acute coronary syndrome. He had gross SCT changes in the lateral leads. Troponin was positive, wide ECG changes, and his creatinine was in the borderline of 1.4 milligram per deciliter. His LV function was although good. So we took him to the lab and did a angiography by the right femoral artery, and that showed this. So there was a critical distal left main stenosis, which was the cause of his problems. Although the LCX stent was patent and the LAD stent was also patent. This is the RC, which was more or less normal. So then we decided to have a plan and wanted to go ahead either with a CABG or a PCI. Now I discussed with him, although he didn't have any family members with him, he's from Kerala. So I discussed with the rest of the missionary clan, and we decided for CABG. I advised him CABG, but because of his age and comorbidities, he did not want to undergo a bypass surgery. So we calculated his syntax score, which was around 18, which was good to go for a PCI. So went ahead with a 7 French femoral route, wired both the LAD and the LCX with a run through and a BMW. And we decided to go ahead with a image guided PCI. I opted for IVUS. Some of the images of my IVUS are not playing. These are some old images, and I was given very short notice to present this case. So basically what I did initially was went ahead and did a NC balloon of 3.510 into the ostial LAD and the distal left main, but it did not give way. So I went ahead and did a cutting balloon flextome of 3.5 8 and did a pre-dilatation all throughout from the LED ostium up to the left knee. And then I did a stent with a 3.5 24. Deployed the stent across the LED up to the left main and left it in the body and did not come all the way to the ostium. Because the IVAS run of the left main did not show any significant plaque beyond the body. So this is the cutting balloon which you can see now. And this is the 410 NC balloon, which we did post dilatation of the stent. Then we took out the wire and recrossed the LCX and did a kissing balloon with 3.30 10 and 2.75 10. There was good result, and LCX was having TB3 flow. So this is the same image playing again. And then we did again a final pot of the left main. This was the final result. So we did a post PCI run of the IVAS, and we achieved 90% of the reference lumen diameter, and we left it at that. So this was my first case, and he's still on follow-up and doing well, although he has been detected with prostate cancer recently. So my case 2 is another gentleman of around 80 years. He presented with STEMI in the night, and we took him to the lab, did an angiogram. He was having Brady also. He was on TPI backup. So this was the angiogram. This was the radial root angiogram. Wired both the LED and the LCX. It was full of thrombus. Now the history of this gentleman is he had a history of paroxysmal atrial fibrillation. So what I basically did was only thrombosuction. And this was after thrombosuction, the flow we achieved. In this case, I did not do any imaging. Did a small P dilatation of the small LCX. And I did not stand there. There was no visible section or thrombus in the artery. So I left him on GP2B overnight and then discharged him. He's still on follow-up, and put him on anticoagulation, which he was not on. Thank you.
Nice case, Dr. Rajanath. Sir, Dr. Saurabh Banerjee and Dr. Chandrasekhar Matale, sir.
Both were really good cases, and I understand that in the middle of a night or the priest where you are studied, obviously there are a lot of stress and tensions, but both were done quite good. I wish the IVAS images we could have seen, but there was some technical problem, but we grant you on that. Any other comments by my colleagues?
Yeah, I think this is one of the case probably if you had a OCT and you could have found out what's the cause, whether it's a rupture or a sort of erosion. In that case, it could have helped you to decide whether to stent it or not. That what Dr. Devasey was talking about. But yeah, I think that's a nice presentation. And for want of time, I think if there's no other question, we can move on to the next two speakers.
Thank you, sir.
Thank you.
I just called Dr. Narasimha Pai for giving his presentation.
Yeah, thank you, sir. Screen.
Please share your screen, sir.
Yeah, 1 minute. Sure. The screen is there, sir. visible?
Visible, sir.
Yeah. So thank you, sirs. And I'll be speaking in the next 10 minutes or so on what is the role of pharmacoinvasive approach in patients with STEMI, whether we should do it for all, even in situations where primary PCI is doable.
Can I
So
call
that's
you
the-
back? Yeah, thank you.
I'm
so much.
audible, right?
Thanks.
You are audible, sir. Please
Yes,
go
yes.
ahead.
Thank you. Thank you.
Yeah,
So
I'm in the
agenda
middle of
is,
the webinar.
I'll
I'll
divide
just
my talk into very small
probably
pieces
about
so
30
we
minutes.
know what
Thanks.
is the definition, what is the evidence for this modality of treatment, what is the relevance in today's day, how is the Indian scenario with respect to STEMI, and what are the fibrinolytic agents that are available. So STEMI management basically revolves around three options. One is the primary PCI, which undoubtedly is probably the best option if available. A primary fibrinolytic therapy is given, the second option, and then you decide on whether you must go for a rescue PCI where a fibrinolytic failure occurs, whether you have to go for an immediate or a facilitated PCI that is to be done within 3 hours after lysis, a pharmacoinvasive PCI within say 3 to 24 hours, or then a deferred PCI beyond 24 hours. So all these are the options which are there in our armamentarium. Now, what is pharmacoinvasive strategy? Pharmacological reperfusion therapy, either with lytics or half dose of lytics plus GP2B3 inhibitors, followed by a transfer to a PCI hospital for an urgent cath or a PCI within 3 to 24 hours. So that's the definition of a pharmacoinvasive strategy. Now, what is the scientific evidence? I will not go into very small bit of details, but I'll try to touch the message. The first trial was the CIAM-3 trial, which looked at pharmacoinvasive PCI, finding the sweet spot for PCI. 197 STEMI patients thrombolized within 12 hours of symptoms and then divided into two arms. One is the early PCI within 6 hours or conservative management, and then deferred PCI or angiography or PCI of the IRA at 2 weeks. And they looked at composite outcomes.
Yeah,
One is
so
the death,
sorry. நான் வந்துட்டு ஒரு
reinfarction,
வெபினார்ல
target
இருக்கேன்.
vessel
நான் உங்களுக்கு எனக்கு உங்க நம்பர் வேற என்னன்னு
Hello?
வரல.
Target
யாரும்
vessel
ரேங்க் அவுட்
revascularization
பண்ணிட்டாங்க.
or any other ischemic
எனக்கு ஒரு
events at
10
30 days or
minutes
6 months. And
சரி
the
ஓகே.
results were very
நான் ஒண்ணு
clear.
இல்ல
If
பை
you
த வே
look
நான்
at the
ஸ்கூட்டிக்கு தெரியாம இதை
ischemic
பண்ணணும்னு
events,
நினைச்சுக்கிட்டு இருக்கேன். பட்
that
திட்டு
is
வாங்கவும் கூடாது. அதுக்காக
reinfarction,
ரொம்ப
death,
பேடா செலக்ட்
death
பண்ணிடக்கூடாது.
or
ஒரு 10 நிமிஷம் கொடுங்க,
reinfarction,
நான் கால்
target
பண்ணுறேன்.
vessel
பை.
revascularization,
தேங்க்யூ.
all of them were fairly better with the early PCI than the deferred strategy. The next trial was the Gracia trial, which again 500 STEMI patients thrombolized with Altipase, divided into early PCI and conservative management, and then looked at what is the death, non-fatal infarct and revascularization at the end of 1 year. And again, here you can see, if you look at the ischemic endpoints, they did fairly better in those group who underwent a early invasive revascularization. You can see here the curve separating between the early invasive and the conservative approach. The West trial, again the same, where 3 group of patients, primary PCI, tenecteplase alone with the usual medical care, tenecteplase with early PCI less than 24 hours. So here, obviously the best results were with the primary PCI, followed by an early invasive strategy, and then a conservative treatment. The transfer AMI, one of the biggest trial of this strategy, almost 1,100 patients with STEMI who received thrombolytic therapy, and those who had at least one of the high risk characters, like say heart rate was high, BP was low, Phillips class 3, or still ST segments non-resolved, divided into two arms, early PCI and standard of care, and then looked at the outcome at 30 days. Again, similar results. Those with the pharmacoinvasive strategy did better than those with the standard of care. The Gracia 2 trial again had a similar outcome. But then if you look at the finer details, that is the tissue perfusion between the pharmacoinvasive and the primary PCI, if you look at the TIMI flow grade, fairly okay, 87, 84. TMP grade again 50, 25. But if you look at complete ST resolution and full reperfusion, the primary PCI subgroup did much better than early fibrinolysis and then going for angiography. This was a meta-analysis published in New England Journal of Medicine, fibrinolysis or primary PCI and ST segment elevation myocardial infarction. Again, the primary PCI standard did excellent, and the pharmacoinvasive arm, they divided into two groups. Less than 75 years received full dose of the lytic, more than 75 years received half dose of the lytic, and then they looked at ST resolution at 90 minutes and decided whether immediate angiogram or a deferred angiogram. If you look at here, no big difference in all-cause death cardiac death, congestive heart failure, cardiogenic shock, slight edge of primary PCI versus the pharmacoinvasive, but statistically, it did not make a big difference. The other point is the bleeding risk, which we always think is higher with the pharmacoinvasive arm than the primary PCI. Statistically not different, but number-wise slightly higher, major non-ICH bleeding, minor non-ICH bleeding, and the necessity for blood transfusion with the pharmacoinvasive approach, especially when you look at in-hospital bleeding complications. So what are the options of reperfusion at a non-PCI hospital today? Transfer for primary PCI is better than the pharmacoinvasive strategy, which is better than fibrinolysis alone. Now, what should be our aim in a country like ours, which is so distinct and so different in managing cases of STEMI? If you have a primary PCI capable center, that means you're working at a primary PCI capable center, then please go ahead and do the primary PCI. If you are in a non-primary PCI capable center, look at the question whether you are able to do the PCI within 30 minutes, within 120 minutes, or whether you are able to transfer him to a PCI capable center within the next 30 minutes. If the answer is yes, then you please transfer him to the primary PCI capable center and go ahead with the primary PCI. If not, then make a decision within 30 minutes and then thrombolize the patient, because you don't want to waste the time with shifting the patient and not receiving any treatment for an AMI. Immediately transfer. If the successful thrombolysis happened, then you can wait. If not, then go for a pharmacoinvasive strategy within 3 to 24 hours. Now, what is the Indian scenario? If you look at the hard facts, the primary PCI is available to less than 10% of the STEMI patients in India. The reasons could be many. One is the lack of awareness, the lack of transfer facilities, the casualty to emergency department to the cath lab time. Lot of time there are financial issues, especially when you are in a private sector where the patient may not be able to arrange the finances for the primary PCI. Obtaining consent for the party from the patient party, also a big issue, because patient comes at midnight alone, brought by the friend, no immediate relatives to give a valid consent regarding the primary PCI. Sometimes the cath lab is occupied if you are working in a busy center with a single cath lab. You may not have the cardiologist round the clock 24/7 in some of the smaller setups. Patient awareness and education for early symptom identification, and they may be presenting to you late, and education required for the general practitioner or physicians to implement early time-dependent STEMI management. Though PCI is the gold standard, yet it remains inaccessible to majority of our patients in our country. This is a small registry which will throw some light on what is the real world scenario in our country. More than 20,000 patients enrolled in this CREATE registry. 60% had MI, 40% in the developed countries. In our country, it was almost 60%. The median time for arrival to the hospital after symptom onset is 300 minutes compared to 120 to 170 in the Western. The time for the initiation of thrombolysis, 50 minutes, close to 1 hour, whereas it is less than 30 minutes in the Western setup. And the last one, the primary PCI hit is only about 9% in STEMI patients. The reasons are very many. And you must also know that the death, reinfarction, cardiac arrest at 30 days is much higher in our country compared to that of the West. We are faced with a pandemic now, and then doing a primary PCI in a suspect COVID patient remains another issue. So what do we do if a STEMI comes during the COVID era? The international guidelines say you spend 1 extra hour in trying to screen a patient if you can do some rapid test, and then don't defer a primary PCI if you're going to extend the window period by 1 more hour. So if it is possible to do that, then again go for a primary PCI. If it is not possible to do that, probably go for a fibrinolytic therapy, and then you can trace the report and then decide whether you're going to go for an early invasive strategy, or if there is a failed thrombolysis, then shift him to a PCI center and then go ahead with the rescue. So why it has to be stressed regarding such an approach? Because time is muscle, and for every 30-minute delay in the treatment of STEMI patient, the 1-year mortality is up by 7.5%. The mortality benefit with primary PCI is lost if the PCI is delayed or the PCI related delay exceeds more than an hour, and practically early fibrinolytic therapy can compensate for a PCI related delay, and proportionate mortality reduction was significantly higher in patients treated within 2 hours of fibrinolytic therapy. So I've put all the facts before you, and this was the consensus statement by the STEM India group in 2014, saying that transfer to a primary PCI capable center only if the transfer time is less than 30 minutes. If not, if it is occupied, thrombolize and then transfer. And if you decide to thrombolize, do it early within the next 30 minutes. Of course, this everybody would be knowing the choice of fibrinolytic therapy which is there in our armamentarium. Tenecteplase, definitely the best option. Retiplase, Altiplase, and streptokinase for economic issues is still used in our country. And if it is streptokinase which has been used for thrombolysis, try to check the angiogram definitely within 24 hours after the lytic therapy. Okay, thank you very much. And if there are any questions, I would be happy to answer.
Fantastic, sir. It's a fantastic presentation. This COVID era where doing a primary PC at night is going to be dangerous because you are not prepared. The team is not prepared for COVID situation. So I asked the expert panel to take position.
Yeah, my one question is like sometimes it happens that the patient has presented the primary center, a primary PCI center, but probably you have one cath lab which is busy or the personnel is not there, and it causes a lot of delay. So in that case, you think one should really consider going for a pharmaco-invasive approach? And if that is the case, then how long will you normally wait? So is it an hour or so, or is it dependent on the time of presentation?
If the patient is still within 3 hours of the AMI and your cath lab is occupied, and you think the cath lab will not be available for you within the 3 hours window period, then we go ahead and thrombolize the patient. And then you can always take a call. You can always take a call within 3 hours after the lytic therapy, whether you need to take the patient in or wait for some more time, depending on the success of the thrombolytic therapy.
Yep, thank you.
So you have any expert comments, sir? Mackley, sir?
You have to unmute yourself.
Sir is not audible.
Thanks. Dr. Pai has done an excellent job, and he has really put the hard data of our Indian scenario. I would like to add one more point. There is obtaining a consent for the primary angioplasty after doing angiography is another difficult task, because the moment in the middle of a night when you have done the diagnostic angiography and you are proceeding for the PTC, at that time, the patient wants to talk to some family doctor who is some maybe homeopath or Ayurvedic or something like that. He has got his own different interests. He says, take a second opinion in the middle of the night. See, that puts the biggest hurdle, and that is the most irritating. So I think that is one of the things which is delaying in our setup. Of course, the rest of the things he has already discussed, and COVID era has also discussed. And COVID era, as of now, what we are following is doing fibrinolysis and do it afterwards. By the time the 24 hours, you get your RT-PCR reports. Because the rapid antigen test has 50-50 sensitivity and specificity. So best way is to do the RT-PCR and do it. Thank you. I think we can move on to the next Dr.
Yes, sir. Fantastic words of wisdom, sir. We'll move to the next speaker. Dr. Sridhar Kasuri is ready with the presentation. Sir, please go ahead, sir.
Yeah. Good evening, all of you. Let me congratulate Dr. Selvamani for conducting an eye show. It's a 42-year-old male patient presented. He didn't have any comorbidities, presented with ACS, inferior wall MI, more than 24 hours window period. ECG showed established MI, 2D echo, RWMF infralateral with mild LV dysfunction. So COVID negative, CT chest normal, drop eye was positive. Other biochemical parameters are normal. Actually, I thought this is a very simple case. I asked my assistant to do the case, and this is the angiography picture. You can see the right coronary totally occluded. And there is a second OM. There is a lesion, significant lesion, and OM not very significant. First OM not significant. But if you see the LAD, there is a mid-tight lesion. You can see the mid-LAD, there is a tight lesion. You can see the mid-LAD here, tight lesion. Then I instructed him to do the right coronary first, then subsequently you can go ahead with the LAD. So both are big territories. Then he started the case. He already finished the right coronary. See, crossed with the BMW wire, dilated with the 2 into 10 mm Tajuna. And this is the angiograph picture. Then subsequently implanted 3 into 38 mm Zane's expedition. So far, it's very good. The result is extremely good and post dilated with a 3 mm NC balloon. This is the final result. So this is completely through transradial approach. Then he wanted to go ahead with the LED. You see the LED, initially the proximal LED you concentrate, it's a big vessel and it's perfectly normal. He has taken only 2 mm Tajuna balloon dilated. See, there is extensive dissection. So then dye flow and patient was getting pain, hypertension. I was sitting in the console room and I was up, suddenly what happened, then I went inside and there is a patient who suddenly became restless, hypertension, sweating. Suddenly picture changed. It's like a simple, like a 15 mm long lesion and concentric lesion. We didn't see any calcification, but balloon also not big balloon and not very high pressure inflation, just 2 mm balloon, suddenly deteriorated. Then we did immediately echo. There was no extravasation, no pericardial fluid collection. You just see that before that LED diameter proximally very fine and diagonal is looking fine. But after that, you can see very clearly there is a diagonal narrowed and OM also, there was a tight narrowing. I will go back and again I'll play. You can see the diagonal proximally, it's OM also proximally, it has become narrowed and LED proximally. Then I told them immediately go and dilate and put the stent to the LED. You see the proximal portion of the LED just after the origin, there is a significant narrowing. What we thought it may have the spasm, dissection, multiple issues and post-dilatation, it's worsened further. You see the diagonal flow is not there, OM flow is definitely tight immediately. At least we thought what is going on, we were unable to understand. I think it's because the dissection, spreading the intramural hematoma, spreading into the diagonal, spreading into the OM branch. L6 is very big dominant. It's a very codominant vessel. It's a very big vessel. OMs are very big. LED was stented with a 3 into 38 mm. Then in emergency situation, we were trying to acquire the IVUS lesion and we were unable to obtain this optimal view because the assistants and then everybody was in a panic situation. You can see the dissection, significant dissection proximally. And you can see this the dissection with the intramural hematoma. And then a stent was implanted. This is you can see the stent implantation. And after post-stent implantation, we did 3.5 into 10 mm dilatation. After dilatation, it worsened further. You see the OM lesion much more worse, and the diagonal also worsened further. And previously, nothing was visible, and no significant disease of the diagonal, no significant disease of the OM. And if it occludes the left circumflex, uninfarcted big vessel already had a right coronary infarcted area. It is a very really panic situation. Then immediately we thought, we did the IVUS also. There was an intramural hematoma, even the because the assistants were coordinating, technician was moving and adjusting, the NIV was put, inotropes were given, and then we could get some images, and then immediately our intention is to stent the first, otherwise there is a difficulty, ongoing pain. You see the OM, very, very significant lesion. We thought it's because the retrospectively, if you see the previous angiogram, when the dissection was there, then immediately you can see, notice that the contrast is flowing into the, you can see very clearly, sorry. You can see the contrast is also spreading into the OM branch and diagonal. I thought it's because spreading of intramural hematoma dissection. Then I took the angioscalp balloon and we tried to evacuate that OM lesion. but there is some flow, but we were not happy with that one. Then we did multiple dilatations. Then we took the, this is 3 into 28 mm stent and implanted the LM to LA. Our plan is first, because already middle AD is stented and proximal AD appearing normal, stent from LM to the OM, so that you can maintain the patency of the LCX and OM. And subsequently, there are 2 options. You can put the stent into the LAD and like a cullet, or you can do the T-tap. So the immediate is, because LAD already protected, flowing well, and now the crossing LAD is very easy. Then we thought instead of collet, why purposefully avoided these, already another bifurcation is there, multiple layers. We don't want to across the, that another LCX, that main LCX. So then the pot was done 4.38, and then pinching of the diagonal again recrossed, then dilated with 1.2 10 mm Tajuna balloon. Then now flow is established, and the LAD was dilated. That studs of the LM2 LCX studs were opened, and that is using 3 into 12 mm balloon, and the LCA and the LCA to OM recrossed again. Studs were opened with 1.5 balloon, and sequential, because we were trying with a 6 French, though we took many new balloons, NC balloons, we were unable to place 2 balloons simultaneously. Probably there was some kink in the catheter. So usually we can place 2 balloons very easily, but here we were finding difficulty. Then we thought we'll do the sequential balloon dilatations. The proximal LAD stented with the 3.5 to 15 mm. And then part was done. So this is the part, and subsequently this is the check angio. Then patient was perfectly fine, hemodynamically stable, 2 stent technique. I don't want to leave without kissing balloon. He was developing spasm with the radial, then switched on to the femoral, and kissing balloon was performed with 3 and 3.5 mm balloons. This is the post kissing balloon. Nicely opened LM, OM is flowing well, and LAD is flowing well. L6 is very well. Part was done with the 3 into 8 mm balloon, and post part we acquired the OCT. You can see OCT. This is the OM OCT. You can see distally, if you observe, there is a intramural hematoma. This is a plaque. You can see the ruptured plaque, dissection. This is the intimal dissection. You can see the hematoma. This is an intramural hematoma nicely, and this is a stent is very well expanded, and this is a compressed intramural hematoma, and the stent studs of the LCX and OM is perfectly fine, but there was some under expansion of the LAD LCX junction. So then we thought, because this was done prior to the kissing balloon, and then this LMCA size is perfectly fine, expanded, very well opposed without any edge dissection. You can see the LAD stand, and all are very well opposed. You can see the intramural hematoma very, very nicely. And then we did the, these are the multiple views. This is the dissected part beyond. There is a block, significant block. MLA was less, it's 3.8. Then we wanted to cover with the additional stent, and additional stent was placed. This is the study of the bifurcation, absolutely opened both. Then subsequently we did the LAD OCT, and distally there is no dissection, and opened very well, expanded very well, opposed very well. Because it's a big vessel, we were unable to obtain the LMCA through the LAD OCT catheter, LMCA to LAD. Then this is the analysis. You can see nicely expanded bifurcation, and the LAD stent is very well expanded. And proximal LAD, the MSA is 10 square mm, SD is 3.6 mm. So arterial LAD 8.6, nicely expanded. We got the, then we did the LMCA run using IVAS also to see is it the proximal LCX by LMCA stent is nicely opened or not. Then IVAS also showed very well opposed stent studs without any edge dissection. This is the analysis. You can see the arterial MCA 14 square mm, diameter is 4.2, again distal MCA 4.5, and you can see the bifurcation is nicely open. So distal stent was placed because the plaque burden was there. There was some dissection was there. So this is the angiogram. These are the final angiograms. You can see LED. This is because of the bend. We have checked again, perfectly fine. LED is flowing very well. So expect the unexpected. Sometimes you may think simple, but it may turn into complex situation anytime. I know it's an experience of everybody go through these type of things, anticipate the problems and try to rectify early. Otherwise, you may fall into fatal ischemic cascade. Pre-PCI imaging assessment of plaque, and any need for plaque modification is definitely required. Probably there may be calcium nodule or thick fibrotic plaque that might have caused the rupture. Intravascular imaging, right, in detecting problems and optimizing deaths. Whatever death result should be optimized. That is very important. Right decision in right time with the right strategy, key for success. Thank you one and all for paying the attention.
Yeah, that's an excellent presentation. And I think Dr. Arun is here with us, and it's always nice to hear him speaking. So Arun, would you like to comment on the case?
It's truly an honor and a pleasure. First of all, congratulations, Dr. Selvamani, for conducting such a fantastic symposium. It's great. Dr. Sridhar Kasturi, I've had the pleasure of having witnessed him firsthand many times. I mean, he's a dear friend. Fantastic case. And yeah, I mean, I couldn't agree more. There is no simple PCI. I mean, and he's one of the few people that really gives hands-on to, to the younger colleagues too. A great save. I think it really underscores the importance of imaging and understanding what is going on. Many times we just kind of say we are cavalier about, all right, it looks good, let's move on. Sometimes you do get unexpected stuff. I think it's crucial when these things happen that we don't skimp on cost. I mean, you saw that he pulled out the IVUS, kind of did the whole thing just because he couldn't image a particular thing on OCT. So I think it really underscores the importance of doing it well and doing it appropriately. Great final result. I mean, I don't, you can kind of debate the final points, but I think it was done picture perfect. That was great. Thank you.
Yeah, thank you.
Thanks, Dr. Arun sir. Sir, Saurav Banerjee sir and Makle sir. Just we'll have 5 minutes of some expert discussion. I'll start the discussion for just starting the discussion. I'll ask one question. How frequently we try to do other vessel angioplasty other than the culprit vessel, non-culprit vessel angioplasty on a routine basis, sir?
Sridhar is asking, who you want to ask?
You are asking.
Sorry, everybody, a panel can give their expert opinion. Non-culprit vessel, how frequently we can do it on?
Yeah.
I will prefer to do it at later date, do the primary PCI, salvage the patient on that particular day, and do the elective PCI maybe next morning or afterwards. And particularly in the middle of the night, I try to avoid such ventures. But Sridhar, I must congratulate you the way you handled the situation.
Thank you very much, sir.
Actually, if you see that particular run, which shows that there is a rupture perforation, that itself shows that there is an extension of the contrast which is going into the OM, but it is the epicranial view. But had you taken one more view at that particular moment, possibly it would have, we would have started with a double wiring and at least secured it, the OM. But now here actually what has happened, your stent is from the circumflex to the left main, and LED you are treated as a side branch, which I sort of could have avoided it. LED has to be given more importance, that's what I think. Of course, it's a personal opinion. The panelists can have their own opinions.
To answer Dr. Aravinda Kumar's question, I think what I normally do, I do the culprit, and then if I find the patient is stable and hemodynamics fine, we have not used a lot of contrast, renal function is okay, then probably I will go ahead and do the remaining vessels as well, because otherwise, that would save the patient some expenses and we don't have to bring the patient again. But as Dr. Makele has said, in the middle of the night when you are yourself very tired, in that case, of course, it's a different issue.
So the next for discussion, I'll just put on one final question possibly. How frequently we can use a mechanical device like a thrombectomy, rotational atherectomy, or a cutting balloon during a primary PCA?
Rotational atherectomy, rotablation, I personally feel no, but there are few anecdotal cases. But cutting balloon or the angiosculpt, you can definitely use in the primary PCA. Dr. Arun Kalyan Sundar, do you want to add anything on this?
I mean, the only thing that I would say is I've done it like a few times. No, typically, here's the thing, right? When you have visible thrombus, I mean, if you look at the indications for rotablation, it's actually listed as a contraindication. But I mean, there are times like, I mean, let's say everything is hunky-dory, you've salvaged the situation, you've restored stuff, and then before you put in a thing, and let's say you've imaged, you've done all this stuff. I mean, let me admit, I've not done it in India, but I've done it outside a couple of times. I mean, once you have the luxury of the patient being stable, there's no visible thrombus, you want to deploy a stent, and you know that balloon's not expanding. So I mean, there is no. It's one of those things where I think it's made to be a bigger deal than it is. I mean, the whole idea is to prep the vessel, whatever it takes, before you deploy a stent. So yeah, I mean, I don't think it should be one of those things where you definitely don't want to do it, but yeah, just be sure if you're going to do it that. I mean, it's for the right indication, not just because you want to.
If you see
I think it should not be the rule to or routine to do the rotablation in the calcium.
Absolutely, absolutely.
If there are the other options are available with us, like cutting balloon, angiosculpt, or even IVL also can definitely help, provided the IVL balloon process at that particular time. See, there are so many options, ifs and buts. But rotablation, I'll keep it as a last option in this situation.
I concur.
Actually, we do rota, particularly when advanced age is there, acute and chronic lesions, particularly aged person, calcified wells. If you see the etiology based upon the OCT, it may be block rupture. Just now he described it may be called erosion or erosive calcific nodule. A lot of calcium, and it can erode and it can lead to a small thrombus formation with acute closure. When you see the imaging also, most of the time, these people will have very critical lesions, and those are because the chronically occluded, slow progression. These patients will not yield to balloons. So when these patients are regularly you try with a balloon, even when balloon is not expanding, it's not a contraindication. We did many times, advanced, particularly more common in aged persons. Aged persons, calcified vessels, when difficulty in grating sensation, if you are able to see with the movement of the balloon, definitely rota is indicated in such circumstance.
Sir, one final question before we wind up the session, because it's getting late, because I want to utilize the opportunity of having so many experts out there. Sir, how do you choose the size of the stent? This is a very basic question will appear, because you know that it is a plaque erosion, plaque rupture, everything was talked about, and there is a component of vasospasm is always there. So do you want to size the vessel based on the visual thing or whatever the imaging technique? Do you want upsize in a primary angioplasty by 0.25 millimeter or something like that? Or you want to say take the same size and deploy it with a nominal or the higher pressure?
And then kind of take it from there.
Saurav Banerjee, sir, you have any answer for it?
Yeah, well, I think this is where imaging probably is helpful. If you are imaging, then it's really helpful to size the stent.
Yes, sir. Everything has to come to an end because already we are running short and we are 20 minutes delay for the close. Thanks for all the presenters, and thanks for the expert panel, and thanks for the co-moderator, Dr. Arun. Thank you very much. It was wonderful having you all here, and all the talks were fantastic, and it was words of wisdom from all seniors. Thank you very much, sir. Thanks for the session.
Thank you. Good night, all of you.
Thank you. Here, once again, Arvind, and it was really a good discussion from you, from your box also. And even box B, the discussions were good, just got over. And to complete, it was a great day one today. We had 4 high-profile lectures, 1 highly informative live case, and 10 exciting case discussions. And we had close to more than 560 attendees.
Very good.
And right now also almost more than 400 people are online now. And I thank each and every faculty of today's session, each one of you for attending and participating in this program. Looking forward to see you each one of you tomorrow at 5 p.m. for approach and management of bifurcation challenges. And I'm sure tomorrow would be yet another exciting day. Till then, take care, stay safe. Thank you very much, Sridhar sir, Arvind, all of you, like to name everybody. Thank you very much for your participation, and then really we had a nice day. Thank you.
Congrats, Selvamani. Really beautiful
Yeah.
show.
Bye.
Thank you. Lovely show.
Amazing job.
Congratulate for organizing this.
Yeah, very nicely organized.
Great job,
Thank
Dr.
you.
Salmani. All right.
Thank
Take
you.
care. Bye,
Thank you,
guys.
sir. Thank you. Thank you.